Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah, saya diberi kesempatan untuk menjelaskan mengenai patofisiologi leukemia. Pertama-tama, saya ingin memperkenalkan diri. Nama saya Rusdalila dari kelas F non-reguler. Adapun yang ingin saya jelaskan mengenai pengertian leukemia. Leukemia terbagi atas dua, yaitu leukemia akut dan leukemia limfosit kronis. Leukemia akut merupakan suatu penyakit yang serius, berkembang dengan cepat, dan apabila tidak diterapi dapat menyebabkan kematian dalam waktu beberapa minggu atau bulan. Leukemia dapat mempengaruhi jalur perkembangan sel limfoid atau leukemia limfoblastik akut, lebih dikenal LLA, atau jalur perkembangannya sel myeloid atau leukemia myeloid akut atau lebih dikenal LMA. Leukemia limfosit kronis merupakan tipe leukemia yang paling ringan, perkembangannya lamban dan bersifat jinak. Gejala leukemia limfosit kronis yaitu anemia, selalu merasa lelah, badan tidak enak, demam, pembesaran kelenjar getah bening, dan secara khusus sangat rentan terhadap infeksi. Tipe leukemia ini berlangsung dalam dua fase. Fase 1 yaitu fase kronis dan fase akut. Pada fase kronis terjadi peningkatan jumlah granulosit, anemia, berat badan menurun, demam, pembesaran limfe. Pada fase akut terjadi pembelahan secara cepat pada sel-sel granulosit yang belum matang. Biasanya pada fase ini penderita meninggal. Penderita leukemia kronis dapat bertahan cukup lama jika fase akut dapat dihindari melalui kemoterapi. Penyakit leukemia yaitu salah satu penyakit bawaan atau kanker yang berpusat daripada darah. Leukemia terjadi apabila badan menghasilkan sel darah putih dengan aktif, seterusnya menghalang penghasilan sel darah merah. Adapun gejala-gejala leukemia umum di bagian sistemik yaitu penurunan berat badan, demam, sering infeksi. Di bagian psikologis, kelelahan, kehilangan nafsu makan. Di bagian paru-paru, mudah sesak nafas. Di bagian otot, kelemahan. Di bagian sendi atau tulang, nyeri atau rasa sakit. Di bagian kelenjar getah bening yaitu mudah mengalami pembengkakan. Di bagian kulit, berkeringat di malam hari, mudah berdarah dan memar. Bintik-bintik keunguan atau potongan kecil yang muncul ke permukaan kulit. Adapun bahaya leukemia. 1. Pada leukemia akut limfosit sel, leukemia menyerang otak atau jaringan sumsum tulang. Ini akan menimbulkan gejala seperti sakit kepala, muntah, bingung, gerakan tidak terkontrol, kejang, dan sakit otot. Sel leukemia juga bisa menyerang buah zakar dan menyebabkan pembengkakan. Adapun 4 tipe leukemia yaitu 1. Akut limfoblastik leukemia, 2. Akut myelogenous leukemia, yang ketiga kronik limfoblastik leukemia, yang keempat kronik myelogenous leukemia. Adapun gambar patofisiologi leukemia yaitu sebagai berikut.
Okay, so let's talk about leukemias. Leukemias are of two types, acute and chronic. The acute ones have sudden clinical onset, whereas chronic ones have insidious onset. In acute ones, we see the blast cells, right? And greater than 20% of blast cells in the bone marrow confirms it. Whereas in chronic, we have mature differentiated cells. The WBC, white blood cell count, is variable in acute. In chronic, the WBC is high. Let's talk about acute leukemias. Acute leukemias are of two types, ALL and AML. ALL occurs predominantly in children less than 15 years of age. And AML mainly occurs in adults but may occur in any age group. Also, ALL can also occur in any age group, but predominantly it occurs in children. And it is KEL-A positive, PAS positive, TDT positive. In AML, we have myeloperoxidase positive and RODS, right? Okay, in ALL, it's basically acute lymphoblastic, so peripheral blood and the bone marrow have increased lymphoblasts. In AML, we have, it is known as the acute myelogenous, so increased circulating myeloblast on peripheral smear, okay? Both of these leukemias are going to present with the symptoms of pancytopenia, that is fatigue from anemia, bleeding because the platelets go down, and infections. Why infections? Because the WBC do not function well. In ALL, okay, in ALL, we can have bone pain because of the periosteal involvement. We can have CNS involvement, testis involvement, and the treatment is chemotherapy by daunorubicin, vincristine, and prednisone. And we know that CNS involvement can be there, so for that we give intrathecal methotrexate. In AML, we give the daunorubicin plus cytosine arabinoside Okay, we have different stages of different types of AML, but M3 stage is a bit unique because it presents with DIC, and what we do basically here is in M3 promyelocytic leukemia, we add all trans-retinoic acid with this daunorubicin and cytosine arabinoside. So all trans-retinoic acid, you're going to add that. Okay, there is a risk of leukostasis. Why? Because when the WBC goes up, there may be a chance of leukostasis, and leukostasis may present with pulmonary edema, ischemic injury, DIC, CNS symptoms. So for that, leukapheresis plus chemo, right? Okay, so chemotherapy basically is of three, we give it in the form of three stages. Like we do the remission induction. Remission, what does remission means? Remission means that you are no longer able to see the blast on the blood and the bone marrow smear, but you know there can be other small cells can be present over there. So we do the remission induction, which we remove about 99.9% of the leukemic cells. Then after some time we perform the remission consolidation, in which we remove the residual cells, residual 99.9% cells. And if the patient is having unfavorable genetics, and does not achieve remission, then we go for bone marrow transplant. Means if the patient relapses or he has got some unfavorable genetics, then we go for the bone marrow therapy. Right, so this is all about the thing. And also there is remission maintenance as well, in which we use repetitive cycles of drug administration to keep patient in the remission. So that's remission maintenance. So that's all about the acute leukemias. If we talk about the chronic ones, chronic leukemias, that's simple. Again, two types, CML and CLL. CML, 40 to 60 years of age. CLL, very, very old patient, like greater than 60 years of age. Therefore, we do not perform the bone marrow transplant. It's useless to perform that. In CML, neutrophil predominant. The WBC count is going to be increased in both of the diseases, but in CML, there's going to be neutrophil predominance. And here, lymphocyte predominance. Okay. All right. The splenomegaly most commonly occurs in CML. Remember about the splenomegaly. And it presents with abdominal pain or leukocyte, right? Whereas in CLL, the splenomegaly may occur, but it occurs in later advanced stages. So when you see a patient of splenomegaly, more likely it is CML. Right. There are going to be smudge cells in CLL. That's also important. Okay, in CML patients, blast crisis can occur. What does that mean? Is that the CML can convert into acute leukemia, that is AML or ALL. That's dangerous. So we need to prevent that. We need to treat before this occurs. So what you do the diagnosis by cytogenetic analysis. And this disease CML is basically defined by Philadelphia chromosome. So Philadelphia chromosome is a very important thing here, right? We need to remember it. And the WBC count is going to be high. The basophils are going to be high. Even the eosinophils are going to be high. And leukemic alkaline phosphatase score is going to be low as a result of immature granulocytes versus leukemioid reaction, which has mature cells. So we have lab score increase. So in CML, we have decreased leukocyte alkaline phosphatase as a result of immature granulocyte. Whereas in leukemioid reaction, we have increased leukocyte alkaline phosphatase. Okay. What you give the patient imatinib. Remember, CML, splenomegaly, Philadelphia chromosome, imatinib. The patient responds really, really well to the imatinib. And if the patient does not respond, then you go for bone marrow therapy. Okay, and you can also give hydroxyurea, but hydroxyurea only decreases the cell count. Okay, now the CLL has got 4, 1, 2, 3, and 4. In stage 0, we have just WBCs increase. In stage 1, we have lymphadenopathy. In stage 2, we have splenomegaly. In stage 3, we have anemia. In stage 4, thrombocytopenia. Okay, so the treatment of CLL is basically if the patient is symptomatic or having an advanced stage, like stage 2, 3, and 4 are considered as advanced stages. If the patient is symptomatic or in stage 2, 3, 4, we give fludarabine, right? And the second line treatment is the chlorambucil. Right. If the Coombs is positive, add steroids. And one thing more, that the CLL is like diagnosed by clinical picture, and we confirm by bone marrow biopsy with flow cytometry, which shows markers like CD19 and CD20. So remember that as well. So if I just summarize whole this topic, it's really simple. The ALL and AML both have pancytopenia symptoms like infection, bleeding, and anemias. Blast cells greater than 20% confirms acute leukemia. Okay, now if we talk about ALL, bone pain, CNS involvement is very common. There is going to be CALLA positive, TDT positive, PAS positive. In AML, we have RRODS and MPO positive, right? Aplastic anemias can also have pancytopenic symptoms, but the bone marrow biopsy shows hypocellularity and contains fat cells, and splenomegaly is absent over there. So just remember this point as well. Whereas if we talk about the CML and CLL, in CML we have Philadelphia chromosome, we have neutrophil predominance, and splenomegaly, and imatinib is given over there. Whereas, and one more thing is that in chronics, the bleeding, infection, and all these symptoms are less common because the WBCs retain the majority of the function. The infection is less common because the WBCs retain the majority of the function, right? So, and CLL, it occurs in a very old patient, like greater than 60 years of age, and splenomegaly occurs, but in later advanced stages. There is lymphocyte predominance, the smart cells are there, and you give the fludarabine if the patient is symptomatic or in advanced stages, and second line treatment is chlorambucil. So that's all about the leukemias.